السلام عليكم. Good afternoon. هنتكلم عن endovascular management of chronic subdural hematoma middle meningeal artery embolization. It's a novel and very promising technique. We are going to talk about the epidemiology, the pathophysiology, therapeutic concepts, and the embolization goals and technique and results. Chronic subdural hematoma represents about 2 to 20 per 100,000 of the entire population, and this incidence increases to 80 per 100,000 in people aging 70 or older, with a morbidity reaching up to 25% and a mortality reaching up to 32%. Understanding the pathophysiology of chronic subdural hematoma is very important and very crucial in order to understand the management concepts of subdural hematoma and the benefit and the technique of embolization. The classic theory has been tear of the bridging vein due to minor trauma, but actually this theory couldn't explain multiple points. In many patients, the initial CT on presentation is usually normal. The hematoma location doesn't necessarily neighbors the bridging veins, and it may take up to 4 to 6 weeks to develop symptoms after trauma. We assume that there is another mechanism of formation of the chronic subdural hematoma that's much more slower than the tear of the bridging vein. This is an imaging of a patient on admission. You can see almost normal CT, and 2 months later you can see the left side subdural hematoma. So the current concept now is chronic inflammatory process following a minor trauma. This concept is mainly formed within the dural border cell layer within the dura, which is responsible for phagocytosis, proliferation into fibrocellular tissue, and delamination after trauma, and this is the layer where the subdural hematoma develops. After minor trauma, a sustained inflammatory process starts to initiate, which causes damage, which induces inflammatory reaction. Pro-angiogenic inflammatory cells are withdrawn to the site of the trauma. Then angioproliferative vessels within the membranes are formed, and the leaky membranes are well developed and starts to exudate and form microhemorrhages. This is the vicious circle within the pathophysiology. Starts also with the minor trauma, inflammatory cells, new membranes formation, angiogenetic factors, vascular endothelial growth factors, formation of very fragile capillaries within those membranes, starts to leak blood and causes continuous inflammation and activation of the membrane, causing a cavity continues to exudate fluid and blood and enters again into this vicious circle. This is another explanation for the difference between the two theories. You can see on the right side the middle meningeal artery branches with formation of neoangiogenesis and inflammatory process and initiation of blood leakage. This is another explanation. You can see. Okay. البوينتر مش شغال. The neoangiogenesis formed within the dural border cell layer and the microhemorrhages and exudation. On the pathophysiological basis, this is an explanation for the CT classification for chronic subdural hematoma and its impact on the recurrence rate. They subdivided the subdural hematoma into 4 subtypes: the homogeneous type, the laminar, separated, and trabecular types. And they found that the laminar and separated types are the most types to have a recurrence rate. About the prognostic factors in radiology for chronic subdural hematoma recurrence, this is a systematic review and meta-analysis, and they found that bilateral hematomas with hyperdense components with laminated and separated types have the most incidence of recurrence. Also hematomas with thickness more than 20 millimeter, and if the hematoma causing midline shift more than 10 millimeters, all those are prognostic radiological factors for hematoma recurrence. Management of subdural hematoma is between three ways: the conservative management, the surgical management, and the endovascular management. The conservative management actually is reserved for those asymptomatic patients with clinical and radiological follow-ups. Statins may improve the hematoma resorption and clinical improvement. Steroids also can improve this process by suppression of the inflammatory process, which is initiating within the membranes, but mostly it can be more beneficial if it's used as pre or post-operative adjunctive therapy. Tranexamic acid also may be beneficial. In symptomatic patients with significant symptoms, surgical treatment is the beneficial option, also, either with bare hole craniotomy, twist drill craniotomy, or craniotomy, but with high complication rates and morbidity. This is the first case of middle meningeal artery embolization that was published as a case report in 2000 for a 59-year-old male patient with recurrent post-operative subdural hematoma, which underwent middle meningeal artery embolization with good result. So why embolization? The recurrence rate after surgical evacuation of the subdural hematoma is up to 33% compared to about 6.5% in embolization. In patients with anticoagulation and coagulopathy disorders like liver disease, the surgery is very risky, and in all patients with multiple comorbidities, البرزنتيشن مش بيتحرك. Those are the radiological prognostic factors: bilateral hyperdense components, laminated, separated, and hematoma thickness more than 20 millimeter with midline shift more than 10 millimeter. The options for treatment: the conservative management, surgical, and endovascular management. As we say, that conservative management is mainly for the asymptomatic patients. Statins, steroids, and tranexamic acid may be beneficial. Surgical treatment is beneficial for patients with significant symptoms, but with complication rate and morbidity higher incidence. This is the the case report that was published in 2000 of a refractory chronic subdural hematoma case in a 59-year-old man with coagulopathy that was successfully treated by embolization. So why embolization? Because the recurrence rate after surgical evacuation is high, up to 33%, 10 to 30% compared to about 6.5% in embolization. In patients with anticoagulation and coagulation disorders, it's risky to go into surgery, and most of the chronic subdural hematoma patients are old age patients with multiple comorbidities, so they could be risky to operate on. Why does the devascularization works, and what's the concept of embolization? As we understood from the pathophysiology of formation of chronic subdural hematoma, the problem is the quick angiogenetic formation of very fragile capillaries in the subacute phase with leaky walls. Occluding them would prevent the constant rebleeds, exudation, and hematoma growth in the subacute phase. So with no rebleeds, the inflammatory process will gradually decrease. The angiogenetic mechanisms will also decrease, and resorption of the hematoma would be initiated. So the goal of our embolization is the devascularization of the leaky membranes to avoid rebleeding and exudation, and to allow the resorption of the hematoma. About the technique, multiple embolic materials could be used: particles, liquid embolic materials, and coils in cases of failure of distal embolization of the middle meningeal artery branches. We all know the advantages and disadvantages of each embolic materials, but we have to be aware that in particles, don't use too much force or pressure in order not to open the dangerous anastomosis with the internal carotid artery. And in liquid embolic materials like onyx or NBCA, you have to be in a widget position in order to achieve distal embolization to reach the leaky membranes. This is a very recent study performed on more than 1,000 patients about the embolic materials used in middle meningeal artery embolization, and they found that there was no difference in radiological improvement or surgical rescue or major complications between the embolic materials in middle meningeal artery embolization. So they recommended that the best embolic material you can use is the most familiar embolic material for you, and the most comfortable for the operator. This is another study showing the difference between embolic materials, onyx, NBCA, and particles, and we can see that there is no big difference between between the different embolic materials, but there was a difference in embolization of anterior or posterior branches of the middle meningeal artery. So you have to embolize anterior and posterior divisions of the middle meningeal artery with a significant reduction in response if you just embolized one of them. The angiographic appearance on the middle meningeal artery angiogram in chronic subdural hematoma, you can see the characteristic cotton wool appearance, and usually it means that this patient will benefit so much from the procedure. This is a very recent classification from Zurich team about the angiographic classification for middle meningeal artery in cases of chronic subdural hematoma. Grade 1, you can see there is no dilatation of the middle meningeal artery and no cotton wool appearance. In grade 2, you can see the starting of the cotton wool appearance without dilatation of the middle meningeal artery, and in grade 3 you can see the dilatation remodeling of the middle meningeal artery with the cotton wool appearance. And grade 3 is the most beneficial from the middle meningeal artery embolization. To what extent we have to embolize the middle meningeal artery branches? This is a recent study this was a very important question on how to what extent we have to embolize or infiltrate with our embolic material. They found that aggressive embolization or aggressive penetration of the middle meningeal artery branches achieved the most benefit, while under or non-aggressive penetration with proximal coiling was in the second place, and the worst results were in non-aggressive penetration without proximal coiling. So you have to achieve aggressive penetration of the middle meningeal artery branches. In case you cannot achieve this penetration, it's preferred to add proximal coiling of the middle meningeal artery. You have to be aware of the dangerous anastomosis within the middle meningeal artery. The most important are the meningolacrimal and sphenoidal branches of the middle meningeal artery anastomosing with the ophthalmic artery, the petrous branch, which is supplying the facial nerve, and the cavernous branch, which is anastomosing with the infralateral trunk into the internal carotid artery. About the anesthesia, it's preferred to use the general anesthesia. If it's not possible, conscious sedation is preferred, but local anesthesia is not recommended at all, because it would be very hard for those old patients to stay stable for the long time of the procedure. You are always using road maps and moving with microcasters, so local anesthesia would be very bad. Those are some of our illustrative cases. A 65-year-old male patient presented with headache 3 months ago. You can see the left side subdural hematoma. This was the middle meningeal artery angiogram. We can see it's about grade 1 to grade 2, no dilatation remodeling of the middle meningeal artery with the starting of the cotton wool appearance of the middle meningeal artery. We achieved aggressive embolization for the middle meningeal artery, and this is the CT after 3 months, and this is after 6 months with complete resolution of the hematoma and complete resolution of the symptoms. Another case, a 53-year-old female presented by headache with a history of minor trauma 3 weeks ago. You can see here the left side subdural hematoma. This is the middle meningeal artery angiogram. And this is about 6 months after embolization with complete resolution of the hematoma and complete improvement of her symptoms. Some of the updates, this is a multi-center experience in more than 150 patients. You can see the significant clinical improvement of the patients with improvement of the subdural hematoma thickness in above 70% of patients. This technique can be also used in and beneficial in very old patients. This is a case in the same study of a 96-year-old male treated with middle meningeal artery embolization with complete resolution of the hematoma and improvement of his symptoms. This is a systematic review and meta-analysis. You can see the significant difference between the embolization treatment and the conventional treatment in the hematoma recurrence rate from 2% to up to 27% in the conventional treatment. And in the single arm of this study, there is a recurrence rate of about 1 case, about 3.5%. Some of the recent randomized control trials, the MAGIC trial in China, which was using onyx as an embolic material in surgical treatment, conventional surgical treatment versus embolization in about 700 patients. The primary endpoint was symptomatic recurrence, progression, or retreatment or death within 90 days. We can see the primary endpoint was reached in about 12% in the conventional group in comparison to 7% in the endovascular middle meningeal artery embolization. Embolies study, and which was also using onyx randomized control trial, surgical in 200 patients, while embolization of the middle meningeal artery in about 200 patients. The primary endpoint was recurrence and progression requiring surgery within 90 days, and this endpoint was achieved in the conventional treatment in about 11% in comparison to 4% in the middle meningeal artery embolization.
Ahmed, please come to the conclusion for the sake of the
The last study is a STEM study, which was using squid, the standard management versus the endovascular embolization. We can see the primary endpoint was reached in about 40% in the conventional arm in comparison to 15% in the endovascular embolization. So what's our take-home messages? Good patient selection is very important and crucial in success of this technique. Mainly patients with failed or recurrence after surgeries, patients with coagulation disorders and anticoagulation therapy, patients with comorbidities, patients with mild or minimal symptoms. The imaging characteristics of activity is recommending us to go into this technique while enhancing of the membranes. Mixed densities and different ages would be most beneficial from this technique. Our conclusion is middle meningeal artery embolization is a very promising technique. We have to understand its pathophysiology because it's a very complex disease. Infiltration of the hyperemic membranes is our goal, and good patient selection is very crucial. Thank you.